We're going to talk today about the dental infections. We're going to review some things that you have already been taught at the pharmacology, plus other steps to see how the infection behaves in the buccal area. Something that we need to make sure is that when we get an infection, it's not only that the bacteria comes to the place, but it's the implantation and the development of the microorganism will be bacteria, virus, of a fungi, living thing, and it will make a reaction to the organism that it sets there. So it's not only that the bacteria, the virus are there, but they are implant, they set themselves in the place, and they start to develop, which means they start to replicate themselves in a great numbers, causing an infection. Now, for the infection to come to pass, we need to have different things. We need to, the microorganism needs to pass through one of the barriers that we have, which are the skin, the mucose, the saliva, the tears, the sweating, the pH of the skin, and the mucose as well. And all the fluids in the body are meant to recheck the bacteria, virus, and the fungi. Now, if we find or a patient comes with an infection, we need to go over different things to make sure we understand what kind of infection was and where is the infection comes from. So we always go for the history. We ask the patient to tell us what happened in an order, in a chronologic order, so we understand since when the patient has this problem. And after we get the story, we go to the physical exploration. We see the patient, we touch, we do pressure on it, we try to look for the place where the infection comes from and trying to understand the origin of that. And if it's already a setup infection, or it's a starting infection, or it's a chronic infection. After that, we should ask for laboratory studies. We'll, that's why we would do that, mainly to understand if it's a chronic infection, an acute infection, it's a fungi infection, of a virus infection. That will lead us to understand those kind of things, as well as the response that the body is giving to this infection as well. So we could see if we have a normal high levels of leukocytes, will mean that the body is handling well enough. But if the number is too high, we could be in a problem, saying that we have already a high reproduction of bacteria, which means that the infection is really a big thing. In the other way, if we see signs of infection and the leukocytes number really low, we can face the opposite thing. A patient who is taking corticoid drugs or any pharmacology that has been depressing their immune system. We should choose what image study we should ask. Maybe just a regular PA X-rays or a panoramic X-rays. Or if we find that the infection is in the soft tissue, we could ask for an ultrasound study as well. Now, we need to ask the patient what kind of medicine he had taken for this specific disease and what drugs or medicine he has taken for other diseases. And if he had an infection before, what medicine he took, because we need to understand and remember that we cannot use the same antibiotic in the same month, because if we use it twice, it won't work. We start with an empiric antibiotic therapy, which means that we always going to choose penicillin if the patient is not allergic. We need to make sure the patient has been hydrated correctly. He's been taking water most of the time. That's one of the things we need to make sure that that will help us with the blood studies as well. We need to make sure we take the source of the infection out. Usually it's the teeth, so we need to make a surgical treatment of taking the tooth out. drain, clean, and we need to make sure we take a small instruments to go around the infections and then make that infection understand what kind of bacteria is affecting their patient. After that, we need to program some surgical washes or cleaning the wound with different kind of liquids that are against the bacteria. And we should choose a selective antibiotic when we have already know what kind of bacteria is affecting the patient. And most of the time we need to close the wound by a surgical repair, or sometimes it repairs itself. Now we have a different classification of the type of bacteria according to different things. Now, according to the origin, it could be an inside infection made from the bacteria that are normally there, or it could be an exogenous infection that is from a bacteria that comes from outside. It has contaminated from the outside to the inside. It could be depending on the location. It could be just in a specific thing. It will be a localized infection. It could be an infection that it's not clear exactly where it is. It will be a widespread infection. Or it could be an infection focus, like the tooth is. So we have a source of infection, it's that, and that could be localized or widespread. Now, before we used to have a different terminology called septicemia, which means that we had a lot of bacteria in the blood and was reproducing itself in the blood. Now it has been taken that term out. We only talk about bacteremia when we have an infection that goes in the blood. Now, according to the infection time, we call about a primary infection. It's just a one-time infection. A secondary infection that could happen if the first infection wasn't completely cured and we have a resistant bacteria probably. And we have a super infection when we get infection. For example, we start with a virus infection and then we get an infection from a bacteria one. Or the other way, we start with a virus infection and then we get a fungi infection. Now, the different times we could have acute infection and subacute infection, a chronic infection, and a latent infection, which means we're going to start. Treble will be close to acute, an infection that rises really quickly. A subacute infection, it's an infection that has been there for some times, and then for some reason, it starts to be acute. So that's where the swelling comes from. And a chronic infection will be been there for a long time and never really does a huge damage, but it's a chronic small damage that has been growing and hasn't been treated. And the latent infection, it's when we have a chronic infection that then gets acute and then goes chronic again. Thank you. No. Sí, ya le expliqué. Sí, gracias. Tati, perdón. Ay. No, ya le. Dígale que. Okay, I'm sorry for that. Now, one of the things that are kind of confusing for you guys especially is how we can differentiate if a patient has an inflammation made by a surgical procedure and when the patient has an infection. What is this for? Because all the cardinal signs of inflammation are the ones in the infection as well. The thing that changes is the timing of that. Now, for both things, we have pain, we have heat in the area, we have a change of color in the skin that is going to be a redness skin. We will have swelling, and we'll have a loss on function. So because of the swelling of all the things, the part who gets infected will not work as well. Correct? That will be kind of the things we need to make sure. So an example of that, if we have a surgical procedure or infection, we'll need blood to fight the bacteria or repair the area who's been in the surgical area. So we have a vasodilatation, we have accumulation of pus or any exudate, and we'll have an increased metabolism, and we'll have a high speed of blood as well. We have a swelling, we make a compression, and that compression will make the sensitive ending of the nerves acute. That's the reason we'll have pain, and that's the other reason we'll have limited on function, because usually the muscles get inflamed and then are not allowed to move as normally as they should do. Okay, so we need to understand what's the patient condition that comes to us. There's some patient that just small infection that you can treat them and see them at a dental office, and other ones that we need to see them at our hospital. So that will make sure we need to understand. First thing, if the patient already is taking antibiotics and hasn't get better, that's one of the things that we need to worry about, especially if the timing of that is more than 3 days. Remembering that when we take antibiotics, even though it starts in the first doses, we can see a decrease of number of bacteria and a decrease of the problems that happens just in the 3rd day of taking that. So it's not something that comes exactly or quickly, but we need to, at day number 3, we need to make sure the antibiotic is working. If the patient has problems swallowing the food, it's another problem that's called odynophagia. If the patient has difficult of breathing and respiratory distress, which it is difficult for him to breathe and get air in there. And the oral opening, how's the mouth open, it's less than 30 millimeters. We'll make sure that we have tension of the suprayoid muscles, which make us understand when we have an infection important that doesn't allow the patient to open up correctly, and that's complicated the eating, the cleaning, and all those things. Other things that make the patient with more difficulty will be the chronic diseases, will be the diabetes, the hypertension, and the steroids and alcohol. Those 3 things decrease the amount of blood that comes through the ending, and the steroids and alcohol decrease the normal defense that our immune system have. Other signs that we need to make sure we are aware of are dehydration, tachycardia, which means their heart is beating faster, and some fever, increase of the temperature of the patient, and lowering of the tension too. Hypotension usually with them too. You will see something that is weak, that it's agitated, that is dehydrated, has tachycardia and fever. Those will be the patients that we need to make sure we take really good care of them. So we need to understand the disease progression, understand and remembering the anatomical location of that. If the area infected is the head and the neck, and we should always try to find out the specific bacteria, virus that is affecting us to correspond to the specific antibiotic treatment. And of course, if there's an infection, it's always a mandate to do an opening, taking the source of infection and clean the infection as well as part of the recovering of the tissue. Now, I have brought to you a small summary of the antibiotics so we can remember those who you already been looking at the pharmacology class. We have the beta-lactams, which will be the ones we always choose from. we have the quinolones, we have the aminoglucosides, we have the glycopeptides, and we have the sulfonamides. So all of them are excellent, but each of them have problems, including things that are not specific with allergy. So any drugs you give to a patient, you need to make sure you know the secondary reactions. For example, in our society or our patients, it's really common that the beta-lactams cause them bacteria vomiting, and it could lead that to diarrhea as well. So you need to make sure you tell your patient that if this has these problems, to let you know. Quinolones will have nausea, vomiting as well. It will make a patient photosensitive, will be damaged with light, and also will have a toxicity in the central nervous system, will can make arrhythmias, and it's not allowed to use in pregnant women in pregnancy. Aminoglucosides, nephrotoxicity, ototoxicity, usually not recommended for the elderly patients. Glycopeptides, it could even become fever, hypersensitive, and sulfonamides, which it's an excellent option for us when the beta-lactams don't work. Will have some other disorders, and it could lead to anemia when it has been taken for a long time. So this kind of like resume of the problems we could face with the types of antibiotic we're going to lead to. Okay, now always any medicine comes with a risk. Usually in our population, we have a small number, but consider it, that are allergic to penicillin. But the normal thing for us, it will be the patient who has nausea. Now, if we don't understand the bacteria that we're leading to, we could use an antibiotic that is not strong enough, or the other way, too strong. So if it's too strong, it could kill the bacteria we're wanting to lead and the bacteria of the gastrointestinal tract, and it will lead to diarrhea, and it will lead to antibiotic resistance if we choose that correctly. So we need to make sure we treat them in the right way. Now, we have some criteria to use the antibiotic as well. We need to decide which will be the administration route. It will be through the mouth, it will be through pills, it will be through the vein. What are the general conditions of the patient? He's able to take the pill or not? Has he been eating? He been taking liquids on? What's the normal dose of medication? We usually will get an infection. We should start with a high dose or a double dose, which normally we do, and then establish the treatment plan. If, for example, if it's just a soft tissue infection, with 7 days will be enough. And if it's an infection of the sinus, we normally go at least 14 days. And if it's an infection of bone, it's an osteomyelitis, we usually need to at least go from 3 weeks to 3 months. So that's kind of like a long time of treatment. We need to see the severity of the case, the aggressiveness of the bacteria, and sometimes we need to use 2 different antibiotics at the same time. That's another thing too. Need to understand the immune system of the patient, if he's fighting back or not. And of course, we need to make sure the drug we want to use is available and it's affordable for the patient. Now, this is one that I have brought to you to understand what are the normal bacteria that affect the places that we lead to. So we have a high number of Streptococcus, we have Actinomyces, we have Streptococcus aureus, Streptococcus epidermis. Those are the more important ones. Remember that those names are in Latin, so usually pronunciation, it's easier for us in Spanish. Now, what happened? When we get a dental infection, we don't get just a single bacteria that is participating in that. We usually get 6 or more bacteria. What we usually get it will be a facultative, anaerobic, gram-positive coccus. Those are the main leaders of the infection party, for say that. Now those who apply in there will be Staphylococcus aureus, Staphylococcus epidermis, Staphylococcus physicum. So those are the ones who end up there. Facultative, anaerobic. What facultative means? Usually that's the bacteria who can survive in both environments. It can survive with oxygen and without oxygen. So that allows that bacteria to be more smart to survive in different conditions and will be the one who starts the infection. So facultative, anaerobic, gram-positive, coccus. Those are the ones who help us out. Okay, so what happens? Why we get an infection? An infection we can get through the soft tissue. That will make an infection if we have a periodontal disease that is really aggressive and it's go to the pulp. We'll get that infection. We have, when we get a fracture for an accident, that could lead to infection through the teeth in the bone, a teeth infection, and if we have a leftover root, that will make an infection as well. Okay. Now, we have some phases. First, we have the inoculation, when the bacteria gets in the site in the beginning. That usually takes to around 3 days to the bacteria to reproduce and cause cellulitis. Cellulitis will be an inflammation of the subcutaneous tissue without a purulent content, diffuse, and maybe a sign of infection. Again, maybe, because the cellulitis looks exactly the same as a normal inflammation for a surgical procedure. So that's the reason we could get confused sometimes and doubt if it is an infection or just an inflammation. So we need to look over the patient to see if it's going to resolve or produce an abscess later on. So we have the cellulitis will be an inflammation of the subcutaneous cellular tissue without purulent content, diffuse, and maybe a sign of infection. Okay. Now, when the time passes, we have the abscess, which will be a limited accumulation of necrotic tissue in the content and a cellular debris. So we have the bacteria that has been there getting the infection, plus the cells that we have that are dealing with the infection too. So their cells also die, and the tissue that is surrounding the infection die as well. So that will be what the pus infection it's about. Now, we have other terms that we need to understand. Phlegmon, it's one of them, and it's the term we use when the infection is at the level of the muscular tissue. And then we have the primary location, which will means when the infection it's limited to the periosteum. So when it passes the periosteum, we'll be talking about, yeah, a widespread infection. Now, this is one of the tables that have cost me a lot of time translating. And this is something you need to understand, but it will help you if you memorize some of the things as well. Okay, so we have the 3 steps. We have inoculation, we have cellulitis, and we have the abscess. Okay. In duration, we'll have the first step will last from 0 days to 3 days. Compared to the cellulitis, it goes from 3 days to 7, and the abscess starts at day 5. Now, or more than 5 days. So it's not a clear thing when the cellulitis ends and when the abscess starts. So we usually need to do that clinical process. Now, the second thing. Dígame, ¿me dijo a mí? Perdón. The second thing, it will be pain. How the pain, the patient feel the pain. Now, when we have in the first step, inoculation, we'll have a pain that is from light to moderate. And the pain will increase in the 3 to 7 days when this cellulitis on. It will be intense to the disseminate area, will be a lot of pain. And in the abscess, usually a moderate and really clear localized pain. So in cellulitis, the patient doesn't know exactly where the pain comes from. He usually says, well, all my face hurts. Now, the size of the infection. In the first step, inoculation, small. In the cellulitis, will be big. And in the abscess, will be small again. Location. Diffuse, hard to know where it comes from. Cellulitis, diffuse again, or more diffuse. And in the abscess, circumscribe, which means it's easy to locate where it comes from. Palpation, we'll have soft pain. So we'll touch it, I will be a little bit of pain, and it will be soft. In the cellulitis, it will be hard, it will be indurated, and will be very painful when we touch it. And in the palpation, in the abscess, will be a fluctuating, and we'll have high pain as well. In the color area, we'll have a normal color. In the cellulitis, we'll have an hyperemic color, widespread or big. And in the abscess, we have an hyperemic, but it will be in the periphery. Now, in the temperature-wise, in the inoculation, the temperature will be normal. We don't have any high temperature. In the cellulitis, we have an hyperthermic area of the soft tissue and the skin. And in the abscess, will be a slightly hyperthermic. It will be a little bit warm. Now, the liquid in there, the fluid. In the inoculation, we'll have an edema, which means we'll have an extravasation of the blood in the plasma. So we'll have like an inflammation there. In the cellulitis, we'll have the bloody serum. And in the abscess, we'll have, something organized. We'll have the pus or the purulent content. The microorganism. Usually we start with an aerobic infection. Then we'll pass in the cellulitis area. We'll have a mixed infection. And when the infection gets deeper and more organized, will be changed to a bacteria that doesn't like oxygen. It will be an anaerobic infection. So we start with the bacteria who likes and handle oxygen, and mixed bacteria who have both things. And that's where the facultative anaerobe comes from. And then we have a more anaerobe infection. So even though the timing of the infection will lead of what type of bacteria we're leading to. Now, this is a patient who came to my workplace probably 3 weeks ago, and he had different signs of infection. He had the first thing, he was sweating, he had tachycardia, and he had clear signs of dehydration. Just see the lips of the patient and see like he's like sweating. So he had a fever as well. So that was the time when he went to the hospital, and this is the time the next day, but he is already with fluid in the vein. He's already clean with all the hair, and he's been giving antibiotic through the vein. But what we see here is the infection. It's bigger and more clear than in here. So it will say that this is going to be like the final start etap of cellulitis or phase of cellulitis, and this will have already an abscess. So I'm sorry that I don't have the actual surgical video of it, but what we did was we did 2 cuts. We did a cut looking for the submandibular space, and the other cut through the sublingual space. And we took the tooth of the infection that was around here. I'm going to try for next time to show you the panoramic x-rays. Now, something important to see is where's the inflammation at, and we need to make sure this is being preserved so we don't are in risk of that closing and having the patient difficulty of breathing. He already have some difficulty in swallowing, so but we helped him out and he's a lot better now. So we give him antibiotics, we open up, clean the wound, and take the tooth out as well. Now we have some spaces that we need to remember. This hasn't been translated all of it, but it will help us out to understand. We have the area where we have the breathing comes from, the esophagus, the area of the breathing. And we have different spaces. We have the facial spaces, which are normally an infection that is not too aggressive, a buccal, canine, and masticatory spaces. We have the suprayoid infection, and the ones who I show you was a submandibular, a sublingual, and a mentonian infection, but it didn't reach to the lateral pharyngeal, who are a danger space as well, with the infrayoid and the prevertebral one, who are the infections who are more aggressive. Now, what we did there, we had first, we did a blood test to see how's the bacteria working. And then we did this to make sure we had an already organized infection with pus. And after that, second, we did a tomography to see where the infection was and how far it has been reached. We have this to make sure the infection is already mature. And then we did the opening, as I told you, and then the liquid in here, the infection, went to make an antibiogram to understand what bacteria we were leading with. Okay, so this will be the things you guys are going to need for this procedure. We'll need local anesthesia, something to separate, something to cut, and the liquid you need to prepare to clean. Sometimes we also use some local antibiotic. In this case, metronidazole we are going to use. And this is the one what we do to flap and to touch the bacteria or the pus to put them in this base to send them to cultivate. Now, after we do that, we need to film this form. We're going to put infection of the mandibule, and we want these tests. We want to make sure what bacteria it is and what antibiotic we can use to fight that bacteria. Okay, so what we're going to do after we get, we're going to stop to go and see the video. Okay. So remember that you have some materia in here. I'm going to upload the videos, the class we're doing that. So when we are going to do and try to understand the bacteria. Okay, wait. Wait. Okay. So we do a cleaning to make sure all the superficial bacteria it's gone. This is a patient that I thought had an infection after a surgery I did. So I already gave him antibiotics. So I want to make sure the bacteria I found out there, it's a normal bacteria, doesn't have a secondary infection. So I press, try to make the liquid comes from. Yes, and that's how we deal and put them in the base, and we're done. So, oh, come on. Okay, so what we have in here, we have the results. So usually we have the different antibiotics who's testing against, and we make in a Petri box to grow the bacteria. So when we see resistant, which means that the antibiotic is not used, we'll have a growing in all the area of the Petri box. But if we have something like this, we look that already the antibiotic is working. Now, there is some tests we usually do in these liquids when we think our patient has a bacteremia on it. And what we usually get is these results. We get something like this. We get the bacteria that we're going to test through, and we have the response. R is resistant, 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 and S is for sensitivity. So it is working. Now, we also have numbers on it. So here you see is a 32, which means a highly resistant, 32 highly resistant, and 1 and 1, it's sensitive, but just a little bit, not too much. So if we want to choose, we probably choose this this drug. There will be a trimethoprim sulfamethoxazole, which is a sulfa, will be the one normally choose in this case because it has some infections that are resistant to. Okay, so this is what they give us to us. They give us if it's resistant or not and how much. And they give us the number of the stronger bacteria or the bacteria who has more numbers on it. So, and we have a conclusion of what we should do. Okay.
Mi doctor, no debe de hacer una consulta. Hay una pacientita que visita al doctor Carvajal, que es esta niña de 15
Okay,
años.
questions.
Necesita ser como hecho un retoque o una operada. ¿Cómo vamos a hacer eso de ella?
Okay, I'm going to give you guys the paper so you can read through the how we should diagnose and handle the infection. No questions?
Yes, teacher, only if you can pass this picture because we can see all well of the numbers of this picture.
Okay, I will upload at the YouTube so you can see the class for today.
Okay,
you can see the paper, so that will be probably good enough. Okay, I'm going to look for the paper so you guys can understand a little bit deeper. I'm going to I'm pretty sure this week is going to resolve the chaos. Even if the president leaves, another one comes or he stays. I don't know what's going to happen, but I'm pretty sure we're going to have normal classes next week. There's no way going to keep longer than this. Okay. I will make the programming classes for you guys. Going to see some topics before we enter to the extraction area that I'm going to give. Okay. So that'll be all for today. And I'm going to send you right now the paper so you can use the rest of the 45 minutes to read. Okay.